Afternoon from here. It's great to see you all again. I trust yesterday's session was impactful. Um, my name is Margaret Uchichukwu. I'm moderating this for today, the first session for today, and I would like to welcome everybody once again. I would also like to know how yesterday's session was for all of you. If nice session, that's glad to know. That's good to know. Thank you. Okay. Um, today's discussion. Thank you, Ronak. Thank you, Theophilus. Thank you, Madura. Thank you, Ahmed. Thank you, Ayad. I'm glad you all enjoyed yesterday's session. Well, today is going to be another very interesting and very wonderful session. So you guys should stay tuned. So I will introduce myself again. I'm Margaret, and today's discussion we're going to is designed to bring together diverse voices across the health spectrum because AMR is not a challenge that any single profession can solve on their own. And by hearing from different World Health Student Alliance member organizations today, we'll be able to understand how each sector contributes to combating antimicrobial resistance. And then we can strengthen collaboration moving forward. So, interprofessional collaboration is at the heart of effective AMR response. And when medical, veterinary, pharmaceutical, nursing, environmental, and public health professionals work together, stewardship and more impactful community engagement. So all of these ties to One Health, and I'm excited to learn from our speakers today. Okay, I'm sorry about that. Hope my voice is clear enough now. Thank you. So, I said today is a panel discussion with most of our member organizations for the World Health Students Alliance. And I'm very excited to hear from our speakers today, and I hope you're also excited to hear from them. So, I would like to introduce our speakers. Our first speaker is from the International Association of Students in Agricultural and Related Sciences. Her name is Janato Fadawasi. Please, can you?
Hello.
Our first
Can
speaker
you hear
to
me?
okay. Yes, I can hear you.
Sorry, hello. Sorry, the network connection is so bad. Can you just repeat? Say.
I said you're the first speaker from International Association of Students in Agricultural and Related Sciences. So I say you should
Thank you.
give just hi to the participants.
Okay, thank you so much. Hello, everyone. This is Ate Firdausi from Yes. Thank you.
We have a second speaker from the International Veterinary Students Association. Her name is Eka Desai, former president of IVSA India and the chair of Standing Committee on One Health. We're glad to have you in our
Hi
presence,
everyone.
Eka.
Thank you. Thank you.
Okay. The third speaker is from the International Association of Dental Students, and her name is Maya Danadna. Maya Danadna.
Hi.
Can you say
Yeah.
hi to us?
Hi.
We're really pleased to have you here. Then the fourth speaker is from the International Federation of Federal International Federation of Medical Students Association, our very own Anna Laya Kopulo, a liaison officer for medical sciences and research issues. Please, can you say hi to us,
Hi, everyone. Thank you for the
Anna?
introduction.
Yeah, we're also pleased to have you too. And the last speaker is from the International Pharmaceutical Students Federation. Her name is Whitney Ann Meniwanda, the coordinator of public health activities. Please, can you say hi to us?
Hi, my name is Whitney Ann. Yeah, thank you for the introduction.
We are also pleased to have you here too. So I'll begin with the questions. And the first question will be going to Miss Jana. I will call you Miss Jana for short. I hope that's okay
Thank,
with you.
thank you. Obviously. Can you hear me?
Okay. Yes, I can hear you.
Okay. Please go ahead.
So, Miss Jana, with 2 minutes, can you tell us what challenges farmers and agricultural communities antimicrobial or pesticide reliance? Oh, can you tell us what challenges farmers and agricultural communities face that make reducing antimicrobial or pesticide reliance difficult?
Yeah, thank you
What
so
do you
much.
think makes the
Actually,
use of antimicrobials and pesticide reliance difficult?
okay, thank you so much. Actually, we are students, and in our community, and the farmers are facing so many problems. First of all, the main problem I think that the limited awareness and training session, because the AMR, this is a new issues in our all over the world. So the limited awareness of the farmers and all over the world's youth is the first key problems in this sector. And then there are some other problems like pressure for higher yields. You can say that in our country and all over the country, I am from the southeast region, and in this region, there is a saying that more pesticides, better yield, and there is so many pressure of the uh, you can say that the food, and we have so many food problems. So the farmers are thinking that yes, we if we use some various pesticides and some antibiotics in the livestock, the pressure of high yields can be reduced. So they use anti microbial resistance and anti you can say some other things to um, increase the livestock products. And also the other thing is the lack of affordable alternative, because you can see in our country or in all over the world, the biopesticides, some other alternatives like microderma and other things to you, what we can use the alternative, because there are no alternatives that are affordable. So the affordability of the alternatives, it can be a major issues in all over the world in the AMR sector. And also the other topic is the climate stress and pest outbreaks, because in the recent years we can see that there are climate stress like the sea rising, and temperature is high day by day. So there are so many problems in this sector. So the farmers can't cope up with this the climate stress without the using of antibiotics and some other things. And I think there are other topic is can be included, that is poor veterinary and the expert, because in we can see that the farmers who are living in the remote region, he or she can't afford the high quality veterinary staffs or expert, and it can be a very big issues in the livestock sector, because we are very much depend on the livestock and agricultural products. But in the remote areas, there are no affordability, and the experts are not that much available in the remote areas. So if we can focus on that topic, that the veterinary and the agriculturists are very available in the remote areas, it can be very helpful for reducing the AMR. That's it from my side. I think I covered all the main issues. Can you hear me?
All right, thank you so much for your answer to that question. Very broad answer. Thank you so much. We have some slight technical issues from our moderator, so I will very quickly jump in here. We have prepared a second question for you, and we would love to hear from your end. How can students in agriculture help introduce or scale sustainable farming practices that protect plant, soil, and environmental health? Thank you.
Thank you so much. Actually, I represent YES, and we are students, and we believe that the youth can play a very important role in this sector, because youth can practice sustainable agriculture and promote the integrated pest management, that is called IPM, to the farmers, because yeah, as I said before, that in the remote areas there are lack of the availability of the veterinary and the experts. So students can help in this sector very closely. And other thing is the encourage the responsible antibiotics and pesticide uses, because in the remote areas, the farmers are not very much famous or familiar with the issues, that what will happen after we use the antibiotics. They are not able to learn, or they don't know about this. So so the students can help in this. And also the other thing is, I believe that development of eco-friendly some solutions from the students, because in this sector I can say that we can arrange some competitions, or competitions on the how the eco-friendly and local used things can help in the reducing of AMR in the local areas. So students can help in this, and also the thing is that they can help in the research sector, because I know my local problem in our years. There is a thing is the act globally and think globally and act locally, because we believe that if we think that this is a global problem, and we look through the surroundings of our of our community, and we can, if we can find a solution, we can spread them all over the world. So in this sector, the students can play a vital role. And also the third and last but not the least is the advocate of the One Health, because this is the high time to incorporate or introduce the thing is One Health, that animal health, human health, and environmental health is all interconnected. If we focus only one thing and ignore other things, it can't be happen. It is not a very helpful thing for us. So it is high time to advocate in the One Health. So I think we youth can help in this, to advocate in our local communities and also the other communities and all over the world, to increase the advocacy of One Health.
All
Thank
right,
you.
thank you so much. That's like a very broad answer to the question. Thank you for sharing your
Thank you.
insight. Next up, we would like to hear from the veterinary students, which will be represented Ika by IVSA. So Ika, I will combine the questions for you. So feel free to answer and keep the answer into like a 2-3 minute frame. So the question will be, how is AMR manifesting in veterinary practice and food producing animals? And what are the biggest barriers to stewardship in animal health? Followed by, how can veterinary students contribute to responsible antimicrobial use on farms? Thank you.
Hi, Violet. Thank you so much for the question. So I will go one by one. That is how AMR is manifesting in veterinary practice and in food producing animals. So we have rising treatment failures in clinics. So vets are increasingly encountering non-responsive infections, especially for UTIs, respiratory infections, skin infection, and post-surgical wounds. We have resistance to MRSP and MRSA, which are showing up in small animal as well as large animal practice. And this is because we have used antibiotics, which we shouldn't have used before. Then we have increased use of last resort or higher tier antibiotics, like third tier or fourth tier, like fluoroquinolones, which are often being used in case the first year fail. The first years fail because we have been using them, misusing them rather, and that is why we are directly resorting to third or fourth tier antibiotics. And this is also a major constraint, and it accelerates the cross resistance between human and veterinary medicine. Also, what happens is we keep the fluoroquinolones in front of us in the clinic. So we kind of tend to reach out to them rather than using the first year antibiotics. So we should keep that in mind. And the next one is AMR spread within herds and flocks in food producing animals living in close quarters. So resistant bacteria can spread rapidly. If the hygiene is not maintained, the feed and the water systems are not cleaned properly, environmental contamination is a big thing, like bedding, manure, equipment. We should maintain this. Then AMR and food chain, we rarely talk about this, but we have resistant pathogens developing. And this can enter through meat, milk, contamination during slaughter of animals or during milking, and the environment through animal waste. Also through humans via handling and consumption. Zoonotic transmission, we all know this. AMR organisms can move between animals and humans through direct contacts, be it farm workers, be it vets, be it pet owners, through the environment, through the food chain. And this is why we say AMR is a One Health challenge and not just a veterinary medical issue or a medical issue that everyone has to deal with. So I will come to the next point. I think it was barriers to antimicrobial stewardship, right? Okay.
Yes, that's correct.
So primarily unfortunately, in veterinary practice, we have diagnostic limitations, especially where I come from. We have limited access to culture and sensitivity testing due to cost, lack of labs, or long turnaround times. Farmers, especially staying in the villages, they do not have access or do not want to spend that much on diagnostics. We also face pressure from our clients saying, please give us antibiotics for just in case, but that is not how it works. And vets do provide these antibiotics thinking that, oh, I might lose a client if I do not prescribe an antibiotic. So there are client expectations in farm animals as well as in companion animals. Owners also like demand instant treatments, be it for diarrhea, be it for skin issues, even when it's not bacterial, they will want to demand treatment that is giving them a quick fix. And there is also a lack of clear guidelines and oversight when it comes to stewardship policies, which vary widely within across countries and continents. We get OTCs across the uh, over the top medicines, over the top medicines, and this is what causes antimicrobial resistance, especially where I come from, because the policies are not enforced well. Then also when it comes to differentiating viral versus bacterial infections, we have to go and inform people that it's not the same. We cannot use antibiotics for a viral disease. And also using narrow spectrum antibiotics when not needed is what is a major barrier in in our field. Also, understanding withdrawal periods in food animals is very crucial. Also, biosecurity gaps. I cannot emphasize enough on this, but poor hygiene, overcrowding, and inadequate vaccination policies or inadequate vaccinations lead to higher infection, more pressure, and then hence more antibiotic use. Lack of surveillance in veterinary sector, this is what I have seen. Human AMR monitoring is improving, but veterinary AMR is still very sparse and making trends harder to track. Now
All
coming
right.
to the last
Yeah,
question.
thank you so
Sorry.
much for sharing those insights. I'm very sorry to interrupt you here, but we are running on a very short time frame. Could you maybe
Okay.
explain to us how you see that veterinary students can like contribute to the responsible use of antimicrobials on farms?
Yes, okay, I'll just keep it short and to the point then. So, point number one, promote preventive health practices. When you go around, explain to people about vaccination programs, emphasize on proper nutrition and hygiene, environment, quarantine protocols, because prevention is equal to lesser infections is equal to lesser antibiotic use. Then advocate for evidence-based treatments. Encourage culture and sensitivity testing and not just giving antibiotics because, oh, maybe I think it's a bacterial infection, so I will give an antibiotic. No. Educate farmers and workers because this is crucial. This is extremely important. Teach them simple practices like how do you do quarantine protocols? How do you clean equipment? This is very basic. And promote biosecurity awareness, visitor control food baths. These are very crucial, and support record keeping and monitoring. So we are using antibiotics judiciously, and also encourage early veterinary involvement. Call the vet early and not after things get worse. That's it from my side. I will not explain all these in detail because we have limited time, but thank you so much.
All right. Thank you so much, Ika, for sharing your insights from a veterinary student perspective. And yes, I'm very sorry for the time constraints. But forwarding, we are going to listen to some insights from the dentistry industry. So, Dr. Mayar, please, would you like to answer to the question why antimicrobial stewardship is crucial in dentistry? What misunderstandings still exist around antibiotic use in dental practice? And also explain very briefly the role of dental research, followed by the question, how can dental students help reduce unnecessary antibiotic prescriptions for dental pain and prophylaxis? Thank you.
Sure. Thank you so much for your question. So, first of all, antimicrobial stewardship is absolutely crucial in dentistry because dentists are responsible for a significant share of community antibiotic prescriptions. Estimates range between 8 to 10% globally, depending on the country, of course, because it's more specific. Unlike hospitals, most dental prescribing happens in outpatient settings where monitoring is limited. So inappropriate inappropriate prescriptions can directly contribute to the to resistance at the community level. So the problem is that most dental infections are local, operable, and do not require systemic antibiotics, and yet dentist antibiotics continue to be prescribed in situations where they provide no clinical benefit. So there are major misunderstandings that drive inappropriate use. First of all, dental pain equals infection that needs antibiotics. This is one of the most common misconceptions. Conditions like irreversible pulpitis, localized abscess, without any systemic involvement, do not benefit from antibiotics. So the definitive treatment is operative drainage on the dental chair, or root canal therapy maybe. But many students and even some clinicians reach for antibiotics because it feels like a quick fix, or because patients expect it or ask for it. The other thing is antibiotics are safer than procedures. This is another misconception, is that prescribing antibiotics is a harmless alternative to immediate treatment. So in reality, antibiotics carry risks, resistance, adverse effects, and disruption of the microbiomes, and often delay proper care. More severe looking swelling, more antibiotics. Some clinicians also misunderstand the difference between localized odontogenic infections, which need drainage, and on the other hand, the spreading cellulitis, which requires antibiotics mainly. So the role of dental research, research absolutely essential in correcting these misconceptions. Surveys like the one we conducted and we published recently among dental students reveal that knowledge practice gap. Students may understand guidelines, but real life behaviors often diverge due to pressure, uncertainty, or habits maybe. So research helps quantify inappropriate prescribing and identify where curriculum and clinical training need strengthening. Evidence from systematic reviews reinforces that antibiotics do not reduce pain or swelling is in most dental conditions, helping long-standing myths to be reduced. Research in AMR also guides the creation of stewardship frameworks tailored to dentistry, which historically has been underrepresented in AMR policies. So research empowers students to become part of the solution by generating data, raising awareness, and holding institutions accountable for improving prescribing indication. So it's critical because in dentistry, because dentistry plays a meaningful role in AMR, misconceptions are still widespread, and research is the tool that exposes these issues and helps us as healthcare professionals to design effective evidence-based solutions. And the other part was about dental students' role in reducing unnecessary antibiotic prescriptions. So dental students are uniquely positioned to change the culture of prescribing in dentistry, because even though they're still in training, they play a major role in reducing unnecessary antibiotic use through education, clinical practice, and also peer influence. So the ways they can contribute in is to use guidelines consistently during clinical decision making. Students can bring evidence-based guidelines like national AMR policies into every clinical discussion. Like when an antibiotic is suggested for non-indicated case, like you can simply ask, what is the guideline recommendation for this condition? So it can shift the team towards stewardship and challenging the culture of like just in case prescribing. Many unnecessary prescriptions come from uncertainty. Students can counter this by asking for supervision diagnosis. It's like either it's odontogenic, non-odontogenic, encouraging operative intervention rather than defaulting to antibiotics, and also learning to manage patient expectations through communication. So because students' fresh knowledge often gives them more confidence in evidence-based practice than some older prescribing habits. improving patient communication as well, because a large part of inappropriate antibiotic use is driven by patients themselves expecting quick fix. They ask for antibiotics. So dental students can address this by explaining dental pain is usually not an infection. Antibiotics won't relieve pain. The real treatment is removing the cause, and antibiotics are needed only for spreading infections, let's say, or systemic involvement. So this empowers patients and reduces the pressure on clinicians to prescribe unnecessarily. Advocating for stronger AMR teaching in dental curriculum itself. Students can encourage schools to integrate stewardship training, provide simulation-based teaching on managing infections, offer case-based discussions, maybe with pharmacy and medical students, to have that equal knowledge, that equal shared knowledge, emphasize correct prophylaxis, indications for endocarditis and implant surgery, for example. So advocacy from students is influential. And participating in and leading research, as IDS always contribute, and it's within their annual plans usually. So just like in your own study, students can assess knowledge and practices within their schools, identify gaps, present findings to faculties, create student-led AMR campaigns and resources. So peer influence is powerful. Students listen to each other usually. Lastly, practicing interprofessional collaboration, working with pharmacy, medicine, public health students ensures assured understanding of stewardship, consistent messaging to patients, a One Health approach integrate early into professional identity. So dental students can reduce unnecessary prescribing by applying guidelines, improving communication, challenging outdated practices, advocating for curricular change and leading research. So with the right support, they have the power to transform the future of prescribing in dentistry, because they're still learning and they do accept the advice early. So yeah, that's all for now from my side.
All right, thank you so much, Dr. Maya, for
Nice.
sharing this empowering message to basically encourage students to become part of the solution. Next up, we will be joined by Anna from the Medical Federation, and she will give us an insight regarding medical students and AMR. So Anna, my first question to you is, from a clinical perspective, where do medical students see the most urgent gaps in AMR awareness and hospital stewardship today? Followed by, what role do young medics have in tackling inappropriate antibiotic use and prescription practices? Thank you.
Thank you so much, Violet, for the question. So I think something very important to say is that, first of all, I saw a lot of similarities with the previous speakers, which is good, because this is why we're here and this is why we're working together. And it's very nice to see that as students, we do understand that interprofessional collaboration is very important. But specifically for medical students and the members of IFMSA, we have seen a lot of lack of confidence among medical students. We are not involved into prescribing while we are in our studies. Of course, it's not legal in most countries to prescribe, but it's very important for us to know when do you give a medication and when you're not, especially for antimicrobials. And also in our education is not included stewardship or interpretation of the suspectability reports. These are some very important gaps that we face, but also being within the hospital culture, it's a barrier itself. We see firsthand the problems that actually led to this problem. The limited resources, as Ika also mentioned, the uncertainty in diagnostics, the high patient load that we have in a lot of countries in the hospitals, and in general, the clinical environment, the responsibility of the doctor to make a diagnosis, and the responsibility to do all the things possible for their patient. Sometimes, for the patient, getting the antibiotic means that they're getting the best health care possible. And it's very difficult to change this behavior. And I have also like personally seen that sometimes when, for example, you need antibiotics and they are prescribed to you, you keep the rest of the box, although it might not be a full dose, and you can actually take, like 3 or 4 pills, but this is actually what's leading and contributing to the problem, because if you take antimicrobials for no reason or for not the full dosage that you need to take, the outcome is not the expected. But it's very difficult to explain this to the patients, especially the older ones that have known antibiotics as something very important, of course. And we have patients that say, oh, I had a headache, so I took some antibiotics because maybe like I'm sick, or like I was coughing, or I had the flu. The flu is also like something very frequent, I would say. And on the other hand, we have parents that are overprotective with their children. So when they are prescribed antibiotics, they might not give them the full dosage, because they see that in 3, 4, 5 days they're getting better, but maybe you need to take it for 10 days. And this is also another big issue, because we don't have the expected outcome when you don't take for the full duration that you are supposed to. And it's very important for us to understand all this and to be there into shaping the change in this field. I think one very important thing is peer education, awareness, engaging with our communities. In the past years, our national organizations have done more than 50 activities in more than 40 countries into awareness for AMR campaigns, reaching millions of people. And of course, as I must say, we're doing a lot of advocacy, working here, for example, on the summit, of course, on a local level, and with WHO, we are part of the quadripartite on youth engagement and in the small working group. And these are all very important things, but of course, what is very important is awareness between medical professors and the local communities, communicating with the patients. Why is this important? The medical students are there. We engage a lot with our patients, I have to say. So it's very important to try to discuss with them and reinforce proper antibiotic adherence. And of course, finally, research and quality improvement is very important. Try to be part of what is happening right now to shape all this surveillance system. I think that's everything from my side. Thank you so much.
All right, thank you. So could you maybe also give like just in a few words, like a brief idea that you have regarding what role that young medics will have in tackling this inappropriate antibiotic use and the prescription and practices? Thank you.
Thank you, Violet. Yes, I think it's what I mentioned last, like engaging with the patients and in being there for our communities. We are the people that are going to have children in the future, or like some people already have. So we need to teach our parents, our neighbors, since we have some knowledge, since we understand that this is an issue, it's very important to start from a local level. We have a saying, and I must say, think global, act local. So I think this is exactly what we should do in this case. Be here, be in these events, be in these networking spaces, understand what is happening right now, understand the policies, discuss with WHO, be there for the change in a global level, but also try to bring this in a local level. And as youth, I think we are the people that bring everything together.
All right, thank you so much for those advocating words. So lastly, we will be joined by Ms. Whitney. She will be talking about how the pharmacy profession is shaping antimicrobial stewardship and access to antimicrobials, especially at a community level. So Ms. Whitney, my first question to you would be exactly what I just said. How is the pharmacy profession shaping antimicrobial stewardships and access to antimicrobials, especially at a community level, which will be followed by the question, what innovations are emerging around diagnostics or stewardship training in pharmacy education that you know of? Thank you.
Thank you so much for the floor. So the first question, how the pharmacy profession is shaping antimicrobial stewardship and access to antimicrobials, especially at a community level. So for this antimicrobial story, we need to understand that stewardship and access, both of them make half of the story. So across all sectors, pharmacy is quite wide. Across all sectors, the industrial, humanitarian, clinical, community, policy spaces, we believe the pharmacy profession holds a very key role in ensuring timely and equitable access of antimicrobials, while it also ensures antimicrobial effectiveness is well preserved. And we need to understand that the access and effectiveness, both of them are quite important. Other than the standard descriptions of pharmacy, the ones that I think most of us know and most of us have interacted with, the point of care testing, the counseling of patients on adherence, the other three that I will emphasize on, rational prescribing and stewardship. Yesterday, during Yusuf's session, he slightly mentioned the antimicrobial categories. They are where he mentioned access, watch, and reserve. And he mentioned where the access drugs are the ones that are easily available. Then the watch are our broad spectrum, and they are yet they have some resistance. Then our reserves are the ones that we use for multi-drug resistance. So in this case, if we redirect a patient who has been given a broad spectrum watch to a safer access, this seems like a very small decision, but it has such a large population impact. And this framework also, the one for rational prescribing and stewardship, also tells us when escalations are justified, and it also ensures access is not restricted at the same expense at patient outcome. So we make sure people get the drugs. If your disease is on the drug that can only treat your disease is watch, or if you have an MDR disease, we'll have to give you the last category because your patient outcomes are prioritized. Yeah. I'd also like to mention supply chain strengthening. We believe in the strengthening of access and the strengthening of the supply chain. In this case, we ensure that there are no stockouts of first-line antimicrobials, which cause now a dangerous fallback. Now we go to the second line and the third line, and it's very relevant in humanitarian crises. You can even see there's a recent study, WHO just emphasized the importance of they are aware in such situations. And with that, pharmacists are ensuring equitable access to essential medicines and services in such crises through specialized logistics, management, rational drug use advocacy, and collaboration with the local communities and organizations. Finally, community-based public health campaigns. Most of it, for the longest time, we used to call ourselves drug experts and we did not have that much community engagement. But it's very beautiful that right now we're going to the communities and having conversations. This is an example of a public health campaign, because you'll find you've invited one of your friends who's not related, who doesn't know anything about One Health, and he or she is learning something new. The whole of last week, I think most of us in all our fields saw pharmacists from diverse fields all over the world, from having walks, community engagements, workshops, hospital CMEs on everything AMR. We also support vaccination campaigns because prevention is key. When we prevent the use of antimicrobials, logically, we're reducing resistance. So as usual, and as we love saying, everything is interconnected. Then also community surveillance. Most of the time we do it on an informal level, where you get to see if, for example, let me just give an example. A patient comes in and the patient has highly resistant UTI. You can clearly see the drug that they're using. For example, if they were using trimethoprim sulfamethoxazole, they're using it as their front line. That's the front line we've been using. The first line we've been using. This is just a signal to tell us that there's some susceptibility shifts. Yeah. Ultimately, we try to strengthen stewardship, not only through restriction, but also by making good decisions so that we ensure the right access to drugs. Yeah, that's it. Oh, that's the first one.
Thank you so much for sharing your insights from a pharmacist perspective. So we are going to wrap up the session very soon, but I would love to hear from all of the speakers from this panel, just one sentence that relates to what do you believe is the next big innovation or trend that your profession will bring to the global AMR response over the next 5 to 10 years. So I would just like to hear one sentence, one call for action, and then we'll move on to the summary. And also, this is a kind reminder to please switch on your cameras so we can ensure that we have good social media pictures. So I would like to start with the agricultural students. So can you tell me in one sentence, to what you believe is the next big innovation in the next 5 to 10 years?
Thank you so much. Actually, this is the best example for us that we are all here from various background like veterinary, medical science, and agriculture. It's a very amazing thing, and thanks for inviting me and inviting yes. And for me, reducing AMR by shifting from chemical independence to the smart and sustainable farming practices, because in our country and all over the world people are dependent on the chemical. So if we can reduce the trend of chemical use, it can be very useful. And also the other thing, I want to mention three things like diagnostic of the soil, that what is need for soil, and also the bio-based solutions to find out to use, and the digital farming tools. That's all, because the time is very short. Thank you.
All right, thank you so much for giving such a detailed and concise answer within the time frame. Thank you for being so considerate. Next up, we would like to hear from the veterinary students. Ika, what do you believe is the next big innovation?
Hi, everyone. I believe the next innovation that we should have is not really an innovation, but something we should take into our hands is education. And I really cannot emphasize enough on this education, right from the primary schools to the postgraduates to the graduates, is very important. And not just that, even the farmers, it's our responsibility to make people aware about AMR and how it can be the next pandemic if we do not use antibiotics judiciously.
All right, thank you so much for giving your one call to action. Next up, we have Dr. Mayer from the dentistry industry. Please, can you tell us in one sentence, what do you believe will be the next big innovation in your field? I think you're still muted.
Sorry, can you hear me now?
Yes.
Yeah, I believe the next major innovation in dentistry will bring to the global AMR response is this shift toward digital prescribing systems. Here in the UK, this has already started, but they're still examining this, assessing that. It started to be implemented in a way across NHS services and dental practices. So digital prescribing allows real-time decision support. For example, prompts when antibiotics are indicated, recommended durations, and safer alternatives, and even the dosage itself. So this helps reduce inappropriate prescription, ensure dentists follow evidence-based guidelines. As implementation expands, I think digital prescribing will become one of the most impactful tools for antimicrobial stewardship in dentistry over the next decade.
All right, thank you so much for sharing your insight. Next up, we would like to hear from the medical students. So Anna, what do you believe is the next big innovation or trend that your profession will bring to the global AMR response?
Thank you so much. I think also with digital health, it would be a lot easier to understand about AMR and engage in the field. So I think the medical students will be there to build those resources, to build the database that we need, maybe also work with AI in the future and try to raise awareness in the general population about AMR.
All right, thank you so much for sharing your insight. And last up, we would love to hear from the pharmacy industry. What do you believe is the next big innovation or trend? Whitney, the floor is yours.
I believe the next decade, one of our greatest innovations will be a renewed drug discovery, because I believe science has advanced, we have improved research ecosystems, and we have stronger collaboration between government, academia, and civil societies. And yeah, they can give us more money though, but yeah, I think with that we can be able to renew our discovery and get new drugs. Yeah. Thank you.
All right, thank you so much to all of the panelists for sharing their insights and comments and thoughts regarding the topic for today's panel. So allow me to very briefly recap for you what we have heard and what the key takeaways are of this session. So we started with the agricultural section, which really emphasized the need for advocacy within the field, followed by the dentistry, which said antibiotics are not just a quick fix, and it's really important to empower our students, the future generation, to become part of the solution. And research can help us to quantify, but also identify the needs for strengthening our protocols. Then the medical students really emphasize the need for best healthcare possible, but also to understand patient expectations. And antibiotics are not just candies, like someone mentioned in the comments. And the same that was mentioned by someone in the comments, which was very interesting to see, is that we should emphasize collaboration and not competition. The veterinary students also mentioned that there is need for advocacy and to make the general public understand the need for us to act now on the antimicrobial resistance. And lastly, as we have heard from the call to action from all of our amazing panelists today, it's important that we emphasize cross-sector collaboration, that we start shifting our focus, and that we start shifting that focus now. Education will play a very major role in the upcoming times, as well as the shift towards digitalization, which was emphasized by the need for digital prescriptions in dentistry, but also the importance of being friends with artificial intelligence in the medical industry. And lastly, the pharmaceutical students emphasize that there is a need for renewed drug discovery. And in the end, AMR is not just our business, it's the business of everyone. And together we can make the world a better place and we can protect our future. So once again, thank you very much to all of the panelists, but also towards our audience, because you have been quite interactive in the chat and it's really nice to see all the comments that you are making. So feel free to drop any questions you have and we can create some engagement there. And without further ado, I would like to say thank you once again, and I will hand over the floor towards Diksha for the moderation of the next session. Thank you.
Thank you, Violet. Hello, good evening, and welcome to Plenary Section 2, One Health and the Innovation Gap. My name is Diksha, the Project Manager for Standing Committee on One Health in International Veterinary Students Association, and I'll be your moderator for this session. Today, we are very honored to have Ms. Usha Lamichane, Scientific Program Officer at the Global AMR R&D Hub. She works extensively on global antimicrobial resistance innovation, mapping, research coordination, and policy support. Ms. Usha, it is a pleasure to have you with us. The floor is yours.
Hi everyone. Hi Diksha. Can you hear me?
Yes, we can hear you.
Oh, okay, great.
Hello, ma'am.
Thanks
Welcome.
thanks for having me. I'm going to share my presentation now.
Move.
That's a bit slow here, but I hope you guys can see my slides now.
Yes, ma'am, we can see very well.
Thank you very much. Thank you, everyone. Thank you, organizers, for having me here today. I was really excited to hear some of the summit yesterday and even today, the first plenary session. Really happy to share the work that we are doing at the Global AMR R&D Hub based in Berlin, Germany. And today I'll focus on One Health and innovation gaps, mostly in the context of one of the most important aspects of AMR R&D, that is resources or funding allocation, and the work we are doing at the hub. So this is the second day of the summit, and I can hear that you guys are experts in AMR, but I guess it's worth being reminded again as often as we can of the scale of this challenge we're facing together. So in 2021, bacterial infections caused an estimated 7.7 million deaths worldwide. This makes them the second leading cause of death, and around 60% of these deaths were associated with drug resistance. Also worth highlighting that these figures do not include deaths associated with other resistant pathogens such as fungi and others, which are also responsible for around 3.8 million deaths per year. Again, this paper also highlighted that AMR is killing more people than HIV and malaria. Despite this fact, relatively small percentage of the general public is aware of AMR, unlike other diseases, since they have had longer awareness raising campaigns. And this is also mostly due to the fact that AMR is a phenomenon and it does not refer to a single disease or indication. Nonetheless, the urgency of this leading cause of death keeps increasing. 1 in 5 deaths due to AMR in 2021 were children under the age of 5, dying due to infectious diseases which were otherwise treatable. Highest burden was seen in the sub-Saharan Africa. However, AMR is on the rise across the world and it's not very silent anymore. In 2019, 500,000 deaths could have been prevented in G7 high-income countries combined if the drug-resistant infections were prevented. Forecasts into the future look very grim as well, with more deaths and economic instability across all One Health sectors. AMR is not just a human health problem, it spreads between people, animals, food systems, and environment. This diagram here shows the core reality of AMR, environmental pressures like climate change, pollution, poor sanitation create ideal conditions for resistant bacteria to spread. In human health, misuse, travel, weak hygiene systems speed up transmission, and in animal health, intensive farming, antibiotic overuse contribute to major reservoirs of resistance. Because these sectors are interconnected, no single sector can solve MR alone, and we need all actors working together. So a strong One Health approach helps protect the effectiveness of antimicrobials across the sectors and improves human and animal health, keeps food systems safe, and supports trade and economic stability. As we know, without action, the situation will worsen. Projections show that by 2050, deaths attributable to AMR could increase by 70%. And where is this estimated highest burden? It's particularly high among older populations and in South Asia. Being from South Asia myself, I always stress the fact that AMR crosses borders, and even if the burden is highest there, the threat is global. And we know that we need unity and stronger measures across the spectrum to mitigate this challenge. So one of the most important measures to combat AMR are the antibiotic arsenal that we have since 1940s. They are the foundation of modern medicine, and all medical procedures and technologies that we rely on today across human and animal health require the safety net of antibiotics. Global leaders are stressing on the fact that we're losing modern medicine in this interview series that we carry out at the Hub, which is available online for you to have a look or listen. The timeline here shown is from a UNEP report, and this this shows commercial deployment of antibiotics and eventual emergence of resistance against them. Antibiotic discovery peaked around 1950s, but then dropped quickly. Every antibiotic in clinical use today is based on a discovery which was made more than 3 to 4 decades ago. Innovation of novel antibacterials is lagging far behind, and compared to how quickly the pathogens gain resistance. In addition, we're exhausting our existing antibiotics. Data from the OECD estimated that resistance to last resort antibiotics, the one clinicians keep for the most resistant infections will be more than doubled by 2035. You've already seen this multiple times, I guess. The WHO review on antibacterials in pre and clinical development year after the year have concluded that the current pipeline is still insufficient to address AMR emergence and spread. The October edition last month shows only 5 agents are considered potentially innovative. 6 of them belong to new chemical class, of which only 2 hit new target. Only 1 has a new mechanism of action. And of only 5 out of these candidates in the pipeline are active against the WHO critical priority pathogens, which is really discouraging, considering the increasing burden. The 3 factors that are widely accepted as necessary for a sustainable antibacterial market are innovation, access, and stewardship. Innovation without access to essential antibiotics is unfair, and without stewardship, it will contribute to increase in resistance and be wasteful. But the current status is that access is poor, stewardship is not efficient, and innovation is lagging behind. So why are we behind the pathogens? Like, why can't we be as innovative in developing antibiotics as the pathogens are gaining resistance? What are the hurdles? This is figure from Pew Trust highlights the major barriers to R&D and market entry, that is the end product use of antibacterials. It is first scientifically very challenging task and could take more than 10 to 15 years to develop an antibacterial. Very high costs are associated with research and clinical development. And after all this time and money, there is a very low return on investment from sales of new antibiotics. You guys are the experts here. Like, these new novel antibiotics are kept on reserve status, often kept as last line treatment options, and hence there is no profit for developers. And because of this dynamic, many large pharma companies have exited the antibiotic R&D space. Most private investments go to areas such as chronic diseases or cancer, with greater probability to earn a positive investment return. Hence, the market for antibiotics is unfortunately broken, and a broken market will not fix itself. So here on the top, you will see the traditional drug discovery pathway, and push funding or push incentives are grants or funding that support R&D from discovery through to approval by lowering development costs. But there are a lot of push incentives in place, push initiatives which support antibiotic R&D in place, but there are major gaps, especially the biggest one after approval, where companies struggle to bring the antibiotics to market without going bankrupt. So we urgently need to reform how we pay for antibiotics. And that's where pull incentives come in. And these pull incentives reward successful development by guaranteeing future income for developers. Traditionally, incentives increase the sales and then increase the income, right? But with antibiotics, this connection must be delinked from volume sold due to stewardship concerns. And the idea of bringing out innovative antibiotics is not to use it. There is this famous example that we all use of fire extinguishers. So if we buy fire extinguishers, we don't want a fire. We buy them just to be on the safe side, just in case we need them, but we don't want to use them. And similarly, we do not want to overuse or misuse our antibiotic arsenal. but we have to keep it equipped. So there are different kinds of policies being developed, but the basic idea is simple: to reward the societal and public health value of antibiotics and ensure equitable access where the burden is highest and provide sustainable returns to developers. So the challenge of AMR is complex. It needs to be tackled at multiple levels across many sectors. Research and development is required to create potential solutions to prevent, diagnose, and treat infections. But resources are always limited. Money is always limited, and we need to make sure that our R&D activities, resources, expertise are all coordinated and prioritized to ensure maximum impact. And this is where we come in. We know, like students know it best. I think I just heard it earlier as well. Money is always tight. And with many global challenges, every investment must count. That's why coordination is essential. And in 2017, the G20 members called for an international R&D hub to reduce duplication and base decisions of resource allocation on evidence. And that's our role, to provide clear, reliable data and insights that strengthen the AMR R&D ecosystem so decision makers can use scarce resources wisely. We are currently a global partnership made up of 20 countries and the European Commission, the Wellcome Trust, the Gates Foundation, bringing together perspectives from across the world. Our newest members are South Africa and Brazil. Observers are Africa CDC, the World Health Organization, FAO, OECD, World Organization for Animal Health. And in addition, we have a stakeholder group comprising of representatives from academia, civil society, funders, and the private sector, who provide valuable expertise and perspectives and feedback. So the hub helps build sustainable AMR R&D ecosystem through 3 pillars, providing evidence for decision making, fostering coordination and collaboration, and raising awareness and visibility. In the next slides, you'll see examples of our activities across these 3 pillars. From the very beginning, one of our core activities has been the dynamic dashboard, our flagship data resource. It's publicly available and provides the most comprehensive picture of AMR R&D investments worldwide. Although there are limitations to how much information we have collected, this is the only available comprehensive picture. The dashboard has 3 galleries: investments gallery, which tracks public and philanthropic funding across One Health sectors since 2017. Second gallery is the pipeline gallery, showing the clinical antibacterial pipeline based on completely the WHO reports. And the third is the incentives gallery, which maps which countries are supporting the antibiotic development. We'll go deeper into these galleries. So today, our dashboard covers over 18,000 projects worth more than 17 billion funding going into MR&D from over 280 funders. With this data, we can ask, what does the global funding landscape really look like? Is that funding producing the products and innovation we need? And where are the gaps and opportunities, and how are the countries incentivizing new antimicrobials? So you're seeing here is the interface of the investments gallery. It gives an overview of AMR R&D investments from public and philanthropic sectors since 2017 only, broken down by year, by research area, by infectious agent, and by the location of funder as well. We won't go through the full dashboard, but I've extracted some key messages from the data. A few take-home messages from the dashboard investment gallery would be globally, there has been a decline in funding for AMR R&D since 2020. We see this most profoundly in the human and animal sectors, but environment and plant sectors are all exhibiting upward trajectory. The majority, we'll see that further down the slides. The majority of funds goes to human health. At our last count, only 5% was being channeled to animal health. We also see differences in funding for research areas and pathogens, with basic research attracting over a quarter of the funding. And there is more focus on therapeutics, which gets 3 times more funding than diagnostics and vaccines. This is an important gap because vaccines and diagnostics, as you know, play an integral and acknowledged role in the AMR response. Most funding targets bacterial pathogens, while there is a gap in fungal resistance R&D, which only receives 7% of the total. This might need more attention, of course. So where is the funding coming from can be seen in this country's report. A lot is going on here in this dashboard. So let me zoom in a bit, and we see that US and EU are the leading contributors, with majority of funding flowing to research area organizations with a fund within the funder's own country. Various so usually, so if the funding is from United States, it's mostly going within United States, although United States is one of the major funders funding projects across the world. Let's get slightly into human health specific now and focus on the funding for antibacterial therapeutics for from public and philanthropic sources. Again, zooming in to see the top trends, we see here, we see an overall decline in funding since 2020, reflecting the general trend, but we also see that specific parts of the pipeline are more affected, especially discovery and preclinical research. The numbers tell us that most of the funding for R&D of new antibacterial therapeutics is coming from a limited number of funders. The top 10 funders provided approximately 85% of this funding. These include funders such as the US NIH, BARDA, Wellcome, and the former German Ministry of Education and Research. Notably, over 20% of the funding was invested in antibacterial therapeutics via pipeline coordinators or funding distributors like CARB-X and GARD-P. The substantial contributions of these funders have been essential in sustaining antibacterial R&D during the period of fragile investment. Another major take-home message here is that we see clear gaps in funding for WHO critical priority pathogens, with exception of Mycobacterium tuberculosis, which attracted 1/5 of the funding volume, which is also supported by a long-term and well-coordinated infrastructure and global alignment. Perhaps an example we should follow on other high mortality critical pathogens as well. This report here is dedicated on animal health research areas. And from this report, we can extract key trends, important trends in animal health investments. First, the funding has dropped sharply since 2020, almost a 40% decrease down to $140 million. This decline comes at a time when AMR pressures in animal health are actually increasing. Secondly, the most of the money goes into operational research, which comprises of surveillance, optimal use, IPC, stewardship, etc. These are important, but they dominate the landscape. Less than 40% of the funding supports product development, meaning very limited investment is going into new vaccines or diagnostics or therapeutics in animal health. And third, we see big gaps in priority pathogens. A large proportion of projects don't specify which pathogens they target, and when they do, major animal threats remain underfunded. This lack of clarity makes it harder for countries and funders to allocate resources effectively. And overall, the message is simple. Funding is going down, innovation is lagging, and priority targeting is weak. A key gap in animal health is the neglect of other animal groups as well. As research is disproportionately focusing on livestock and poultry, leaving other animals with less studied health issues and disease prevention strategies. This can lead to inadequate veterinary public health frameworks, insufficient reporting on zoonotic diseases, not directly linked to food production, and fewer resources for research that does not have direct economic benefits. Next is the report on environment. We have a report focused on environment health. This slide shows that environment AMR funding has actually increased since 2017, but it is the overall funding into environment health represents only about 1% of the total MR investments, which is extremely low. Most of this limited funding is directed towards wastewater, with very little going to soil and surface water and others, even though these are also key pathways for resistance spread. Overall, environment sector remains underfunded and underprioritized, despite its central role in driving transmission of AMR in particular. Plant health, the report focused on plant health also shows that there has been an increase since 2020, but overall total funding remains lowest in global AMR R&D investments. Most funding goes to crops, fruits, cereals, and vegetables, reflecting well where the plant production pressures are highest. The landscape is dominated by basic research, which with limited investment in applied or product-oriented work. Overall, the plant health remains an underfunded part of One Health response, despite its importance for food security and environmental pathways of AMR. We do have to consider the caveats and limitations of our data collection. This is not exhaustive, but this is the most comprehensive collection of data as far as we know, and highlights important trends across the world. We also have one report dedicated only to projects that cover multiple sectors across cross-sector projects. Across these sectors, we see 3 clear R&D funding gaps that are slowing progress. And firstly, there is still very limited investment in truly One Health research. Funding remains siloed into human animal streams, which mean we have too few integrated studies that look at AMR transmission, burden, and interventions across the sectors. Second is the cross-cutting tools are consistently underfunded. Diagnostic surveillance systems, data integration platforms, and environmental monitoring receive fragmented support, even though they are essential for coordinated AMR control. And third is, even though it's the most funded area, it is not enough. Investment in translational and implementation research is still very low. We struggle to move innovations from the lab into real world use, whether that's vaccines, stewardship models, or other technologies across human, veterinary, and environmental settings. These gaps show why coordinated One Health aligned funding is so important for delivering impactful MR solutions. Let's have a look at our special report on the dashboard, which is on the funding distributors. Because developing new antibiotics were not profitable, many private companies left the field, and public organizations and charities have stepped in to create partnerships like GARBEX and GARP to fund and accelerate R&D. Pharma has also contributed a bit through AMR Action Fund. These global partnerships act as funding distributors, channeling money from governments and philanthropic organizations. And to avoid double counting, we produce this special report that tracks both deposits into the funding distributors and their disbursement into AMR R&D directly. CARBEX are, I'm sure you've heard of them, global non-profit partnerships which accelerate antibacterial products from addressing drug-resistant bacteria, integrate solutions for prevention, diagnosis, and treatment of bacterial infections from basic research to first-in-human clinical trials, while GARP develops antibiotics from later stages clinical trials to the launch of new drugs, and also improves access to antibiotics for appropriate use, focused on low middle income countries. Sorry. Next, in the dashboard is the pipeline gallery. And the pipeline gallery shows products in clinical development or those which have recently been approved. This is based on the WHO reports, and in addition to antibacterials, we also have added bacterial vaccines in clinical pipeline. We've presented this data from WHO overviews, and if we want to see whether funding in the investments gallery has been translated into products which we need to mitigate AMR. Here you can see that very few candidates advance to the late clinical stage and very few are eventually marketed. Third gallery in the dashboard is the incentives gallery, and the incentives gallery displays and tracks in a single interactive page all incentives that aim to improve R&D across the whole value chain and the functioning of markets and the broader antibiotic R&D ecosystem. So we've recently updated this with a global view of full incentives by country, and we aim to provide a regularly updated global snapshot of incentives. First, across the value chain, initiatives are grouped under 9 categories. There's 9 boxes, and users can access further information on each entry and access various external links and documents within this gallery. On the left side, or the push side of the R&D, are the major initiatives supporting early stage R&D. As we mentioned earlier, one of the largest public-private actor currently in this early stages is Carbax, and they take a clearly defined product from early hit to lead project to all the way to the proof of safety in humans to phase one. I will not go into more detail here, but let's look under box 7. On the right side, the pull incentives that are being developed or implemented currently are listed here. And UK was the first to launch a subscription model here. In 2022, they to give you an example of incentive model, the UK in their subscription model implement a Netflix type subscription model where NHS England pays fixed subscription type amount to pharma companies for supplying select antibiotics. That way, the revenue is delinked from volumes used as they're paying for the value of these antibiotics to the people of UK in subscription basis. There has been progress in this sector of incentives as well, and there are different kinds of incentives in progress at different stages with the same aim of creating sustainable revenue and ecosystem for developer to strengthen the pipeline and foster innovation. One thing to note here is that even the rich, high-income, mature health systems struggle not only to bring these products to the market, but to also to the patients. So health system policy innovation might be sometimes harder within mature health systems as well. But these are the funders with most resources, and they also dominate the global uptake in innovation markets, and they are the one who shape what products are accessible today and crucially develop tomorrow. Hence, the incentive policies at this level is important for the global market as well. Box 8 is on access, and access to priority antibiotics should be taken up as a key factor in the AMR response because there are still significant amounts of deaths due to lack of available antibiotics than lack of innovation. And LMICs are worst affected by limited access to antibiotics, leading to higher mortality rates and increased healthcare costs. Secure is an example of an initiative being developed by GARDP and World Health Organization. Their mission is to provide sustainable and equitable access to antibiotics for patients around the globe, with specific focus on vulnerable populations in LMICs. Our new update to the incentives gallery is the brand new country by country mapping of incentives. This interactive feature makes it easy to see at a glance which countries are taking action and what approaches they are using. For example, you click on a country and immediately get a snapshot of its full incentive commitments. You can also access information on current status, historical and broader context, links, and further information across the different country initiatives. Talking about pull incentives, one of the big part of our work at the Hub is running dedicated working groups where we bring members together to support collective coordinated action across both the push and pull spectrum. One of this is our pull incentives working group, which was set up to foster informal dialogue between countries and policymakers. The idea is to share lessons learned, compare experiences, and refine national approaches. In other words, thinking globally while acting locally. As an example of impact, we are glad to have played a supportive role in Canada's journey in making the policy case for its new antibiotic access pilot. Another important health working group within the Hub is the One Health AMR Research Working Group. It's co-chaired by Germany and World Organization for Animal Health. This group brings together hub members, funders, policymakers, and international organizations such as FAO, World Organization for Animal Health, along with other invited experts and researchers from all One Health sectors. It serves as a practical platform for countries and partners to share perspectives and experiences on how they are implementing their One Health AMR responses and approaches. The goal is to support the implementation and funding of One Health AMR research and development, while also helping strengthening the dynamic dashboard through data validation and insights. What makes this group valuable is its informal and collaborative nature. It provides a relaxed space for stakeholders to exchange views, identify challenges, and coordinate more effectively across sectors. It is an important mechanism for aligning efforts around the quadripartite One Health research agenda and advancing integrated MR solutions. To support these working groups discussions and provide evidence, we publish policy briefs and reports in the AMR space, which are available on our website. I want to highlight particularly two relevant reports here today and share some key messages. First is the collaboration with IDRC Canada, who led this study together with us on animal funding patterns for animal health R&D in low and middle income countries. Some key takeaways from this analysis are relatively little funding goes directly to research institutions in LMICs. Both the funder and the lead research institute are often based in high income countries. And moreover, we find that there is a gap in funding for aquaculture related R&D, which with only 10% of funding allocated for this sector in LMICs and only 11% globally. Given the diversity of production systems in aquaculture, combined with major environmental risks associated with water contamination, make aquaculture fertile ground for MR research. The trains highlighted here provide a starting point to address potential funding gaps globally and inform research funding agendas, highlighting that the global solutions are required to do with the involvement of LMIC funders, research organizations, and policymakers at all levels and as equal partners. The second focused study on identifying gaps and opportunities for development of veterinary vaccines against the World Organization for Animal Health prioritized bacterial infectious agents, a list of diseases and pathogens for which vaccines could reduce antimicrobial use in animals. So we collaborated with World Organization for Animal Health for this study. And the key results from this exercise were that around half of R&D funding for vaccines development is directed towards prioritized bacterial infections in pigs, poultry, cattle, and fish. However, what we find is that not all the prioritized agents are covered, and that in certain animal groups, especially cattle, the majority of the infectious agents in the prioritization list are not being addressed by the current foreign R&D funding. We see this data and insights being a foundation for prioritization allocation of funding resources and efforts for R&D in animal vaccines research. Also, WUHA is updating their priority animal pathogens soon. They're working on it this next year, and we hope to support them identifying the trends and gaps as well. Our data was also used to inform the Lancet series on AMR, helping to strengthen the policy case for investing on AMR-RD, revealing the state of the funding of landscape across various sectors in AMR. We also work to make sure that the light keeps shining brightly on the AMR challenge, especially the R&D aspects of the AMR challenge, and we participate and host sessions at numerous high-level conferences and workshops since 2021. We have been submitting a report on R&D landscape to the G7 countries. We've been involved in the G20 meetings to try and keep AMR high on the agenda of these high-level meetings. We've been engaging with policymakers at this high level, sharing evidence base for better decisions and providing interventions to keep AMR high on their agenda. Without action, AMR will only get worse. But to end on a positive note, with improved access to healthcare and antibiotics, we could avert up to 11 million AMR attributable deaths by 2050. And we look forward to supporting the independent panel on evidence for action against AMR to help accelerate action and deliver sustainable impact. Before I close, I'd like to invite all of you to explore our dynamic dashboard and use the publicly available data for your own research, advocacy, and especially youth engagement. At the Hub, we are dealing a lot with funders and policymakers at high level, and we are now keen to create more opportunities for young people to get involved, perhaps through the use of data in their own creative ways, data challenges or collaborations, or even dialogues with policymakers. We look forward to partnering with you and hearing your ideas, and thank you very much for your attention today. Thanks.
Diksha, we can't hear you.
Can you hear me now? Okay, thank you. Thank you so much, Ms. Usha, for that incredibly insightful presentation. You highlighted some truly important points, including how the One Health approach is essential for addressing AMR, the gaps in current innovation pipelines, and the need for stronger coordination, funding, and research priorities globally. Your emphasis on data-driven decision-making and the importance of investing in early-stage R&D, surveillance tools, and equitable access to new solutions was especially valuable for all of us as young professionals entering this field. We deeply appreciate your time and expertise, and we are grateful for your contribution to the Global AMR Youth Summit 6.0. We will now move to the Q&A session. Participants, please type your questions in the chat box or use the raise hand feature. You can raise your hand. All are requested to drop your questions in the chat box, or you can also raise your hands. Okay, so we have questions. Our first question is only awareness brings down AMR without strong laws and advocacy? Thank you for that question. Miss Usha, would you like to respond?
Hi, yes, of course. Thank you for the question. Oh, definitely not. I think we all know that, yeah, like awareness is a very big part of bringing down AMR, like mitigating this challenge that we have. And we need to do much more in this aspect, but strong laws and advocacy and a strong like political willpower is extremely important. And I actually figured this out at work because I was a researcher earlier. And when you are working in a lab, you don't really have this big perspective of how the policy world works, and strong laws, like we need a lot of advocacy for AMR to even be on the agenda of policymakers and world, like um, the powerful funders. So um, strong laws and advocacies are extremely important, but and we would not be able to do this only with awareness, but they go hand in hand as well. Without awareness, we cannot make strong cases for advocacy and laws or policy making. We need awareness, we need evidence base so that we can prove to law policymakers why we need stronger laws and yeah, policies to mitigate AMR. Thanks.
Thank you for your answer. We have another question, that is, if new antibiotics take long to develop, what could be other solutions to combat AMR besides conventional antibiotics? What are your thoughts on it?
That's a great question. It's definitely um, antibiotics are already taking very long to be developed. That's why we have to invest more in other non-traditional products as well. In addition to that, we have to invest in diagnostics and vaccines for infection prevention control. Correct diagnosis, of course, helps stewardship and proper optimal use of antibiotics. So all these other surveillance, of course, is very necessary. So everything is like they all have to go hand in hand because we are already quite behind with innovation. So we have to really invest more in especially diagnostics, vaccines, and surveillance already is quite surveillance is always already being quite focused by WHO, as you all know. Yeah, so that is what I think. Diagnostics and vaccines, IPC should all be focused on, and more investment should go in this area as well.
Thank you so much for your answer. Moving on to the next question we have is, what laws can reduce non-prescription use of veterinary antibiotics without harming the farmer's livelihood, especially in low-income regions with poor diagnostic facilities?
That's a great question, and I think I'm not an expert here for this question, but I did hear the panel earlier, and there were quite interesting perspectives there. I think um, I'm looking at the question again. Um, in low middle income settings with poor diagnostic facilities, yeah, what laws can we use? Like I have an example from my native country, that is Nepal, that there are actually laws to ban like antibiotics like colistin for in animal health, but apparently it doesn't really work very well. So like implementation of laws is also a very big thing to like to stop um, use of antibiotics in veterinary animal health, but I wouldn't be able to, like, I'm not able to say exactly what law should we, like, more than new laws, I think implementing the laws that are already in place is also a big thing.
Okay, thank you so much. Thank you so much, Ms. Usha, for your valuable insights, and thank you to all participants for engaging with us. This concludes our plenary session 2, One Health and the Innovation Gap. We now move forward to the next segment of the event. Kimia, the floor is yours.
Hi everyone. My name is Kimia. I am part of the IADS workforce focusing on public health. I'm delighted to be here to be your moderator for this session. I would like to thank Usha for that insightful discussion on the One Health and the innovation gap. And now we move on to the workshop session. The topic is Imagining a Cure, Tackling AMR Through Storytelling, and our incredible workshop facilitator today is Alison Humphrey. Before we begin, I'd like to briefly introduce our workshop facilitator. Alison Humphrey tackles collective action programs and science misinformation through citizen science fiction, a participatory mixed reality storytelling methodology. Humphrey's 3 decades directing for digital media, television, and theater inform her research creative practice. Her MFA pioneered motion capture interactive theater, while her pre-pandemic PhD project, Shadowbox, reimagined immunization through a participatory superhero story world. This work, co-created with youth across 3 continents at the Bajamujik Storytellers, the Royal Academy of Dramatic Art, and the Desmond Tutu Health Foundation, was supported by a Veneer Scholarship and won a Governor General's Academic Gold Medal. The Lancet called it undoubtedly one of the most powerful and playful ways to illustrate both the individual and population-level implications of community immunity. Currently a postdoctoral fellow at York University's Global Strategy Lab and Immersive Storytelling Lab, Humphrey is developing the story algorithm role-playing cycles methodology to engage with vaccine hesitancy, climate paralysis, and antimicrobial resistance. Allison's work perfectly bridges the creative and the strategic, making her the ideal person to lead us through this challenge. Allison, it is great pleasure to have you with us today. The floor is yours.
Thank you so much, Camilla, and thank you to the entire committee for inviting me. This is a fantastic honor to be here with everybody at the Global AMR Youth Summit. It sounds like you've been having an amazing summit so far. I hope that everybody's still got brain cells left at the end of the day, and I hope that this will be a little bit of fun to kind of give you a launch pad into the final day. So let me share, hang on a second, I will share my screen. I think I'm going to have to replace the current share. You've looked at my picture long enough. There we go. Got it. All right, here we are. As said, my name is Alison Humphrey. I am a postdoctoral fellow at York University in Toronto, Canada, at the Immersive Storytelling Lab and the Global Strategy Lab, sort of straddling between the arts and the sciences, which is what I did for my PhD a little while ago. Here we go. So in my work as a creator and researcher, I explore how we can use role play to develop skills vital to a good life in a thriving society. The interactive storytelling forms I work with are a form of participatory mixed reality storytelling that I call citizen science fiction. For those who haven't come across the term citizen science before, it's sort of like citizen journalism, where non-professionals contribute to scientific research alongside professional scientists. For example, where amateur birders record sightings of birds and upload them to a research website. As for science fiction, well, I hardly need a slide for this one. And then there's the participatory culture idea of a fiction citizen. Here's a photo from 1977, the year the original Star Wars came out. That's my little brother on the left, dressed as a Jawa for Halloween, and I decided that the best character to dress up as was an X-Wing fighter. By cosplaying, we were both, in a sense, becoming citizens of this fictional story world. Altogether, these elements add up to citizen science fiction, a concept that I developed as part of the PhD in Cinema and Media Studies that I finished 2 years ago. This is a QR code and a bit.ly link for a project that I've been working on at the Global Strategy Lab and Immersive Storytelling Lab, which we have had various names for, but at the moment we're calling Art and AMR. And we were inspired by the ways that arts are used to communicate with the public about antimicrobial resistance. This one is by a member of our group workshop that we convened a year ago, a graphic novel that came out before the pandemic. So it was sort of followed a pandemic of antimicrobial resistance. And then here are a number of things that I'm just going to flip through. There's a feature film from South Africa, puppet theater from Thailand, musical theater from the UK, an animated GIF explainer from Australia that was during the pandemic. This particular pair of writer and illustrator created some of the most famous infographics of the pandemic. They were the ones who kind of created the Let's Flatten the Curve cartoon at the very, very earliest stages of the pandemic. Here's a youth creative hackathon from Cambodia. A card game that's just coming out from the United States, from the Center for Advanced Preparedness and Threat Response Simulation. Data visualization from a fantastic organization called informationisbeautiful.net. An animated explainer video. One of my favorite things, explainer videos teach me everything I need to know. This is a researcher, another PhD researcher who works with people to create mini films about their real life stories dealing with antimicrobial resistance. You've got the laboratory where Alexander Fleming discovered penicillin, which has been preserved in London at the Fleming Center. An immersive installation called The Pathogen of War, co-production between the US and the UK, including an Iranian researcher. A children's book for ages 8 to 12. An animated explainer video from Germany, as I said, one of my favorite things. And so all of these and more were our inspiration when, for 2 days 1 year ago at the Wellcome Trust in London, England, 22 artists, health communicators, researchers, and policymakers gathered for the workshop Through the Petri Glass. Day one focused on surfacing and sharing the group's collective intelligence. And the whole thing was graphic recorded by a team of artists who came up with sort of images that reflected the insights that people came up with over the 2 days of the workshop. I'm just going to flip through these very quickly. It's a wealth of material that we're just about to be publishing in a book that I can send out to the conference organizers, and they can forward it to the group. This was people saying, you can make games about AMR, but you have to make them good. You can't just make a game and throw it out there and say, this will teach people, because they've got some good games. So then day two, it explored artistic interventions to amplify awareness and inspire global action. The participants carried their diverse personal connections to AMR. Some were driven by deeply personal stories and others by a transformative academic moment or a lifelong passion for storytelling. Most of the participants had previously created artistic or storytelling interventions around AMR awareness, many of them funded by the Wellcome Trust. And at the high point of the workshop, participants self-selected into one of 4 groups to work on pitches for a new intervention. So this was the idea market, where these 4 groups pitched their ideas, and 3 of them grew groups out of the workshop that then worked together over the past year, and the Global Strategy Lab gave seed funding to them to develop their ideas towards a proof of concept. The first project in development is a time travel counterfactual called Genesis 1928. What If, this participatory research and storytelling initiative, explores alternative histories springing from the question, what if penicillin had never been discovered 100 years ago? Those of you who follow the Marvel Cinematic Universe will recognize the concept of a multiverse of branching alternate timelines. Through immersive dinner table conversations with historical and contemporary characters in different global communities, the project will examine how farming, medicine, and society might have developed differently without antibiotics. Through community-led storytelling from Brazil to India and Uganda to the UK, it explores local perspectives on health, authority, water, and nature, creating an immersive experience that reframes our coexistence with microbes. This particular image is from a different play called Top Girls by Carol Churchill, but it also puts characters from different cultures and centuries together at a dinner table. The project is called The Microbial Realm, The Resistance Rising. It's a pilot immersive experience that combines role play, gamification, and digital storytelling in a Dungeons & Dragons style gameplay format. This fantasy meets reality game turns players into microbio wizards and antibiotic alchemists who must work together to stop the spread of superbugs. Instead of traditional hit points, enemies have resistance meters that build with antibiotic use. The prototype is being adapted for classrooms, exhibitions, and a future tabletop release. The third project, Surgeon X, is a unique, darkly comic medical thriller set 20 years in the future in the midst of an antibiotic apocalypse. A far-right government comes into power in the UK, introducing an antibiotic austerity act. Surgeon X allows us to explore a world that we really hope never comes to pass. A what-if thought experiment for a place we don't want to be. The Global Strategy Lab seed funding is enabling the creative team to update and adapt the Surgeon X comic, which you can go and read right now online, to a multimedia expansion into an immersive web experience. Here are some of the behind-the-scenes materials that they created that will be going into the immersive experience. These are posters from this apocalyptic future. So all of those are examples of the way that you can bring the arts into sharing messages about antimicrobial resistance with the general public. But there are other ways that people who are non-artists can think about how they communicate about AMR with the public. The Wellcome Trust created an amazing project called Reframing Resistance on how to communicate about antimicrobial resistance effectively. And again, you can find this on the Wellcome Trust's website. They created a video, which I'm going to share now. In fact, let me just very quickly stop sharing and make sure that I have shared with sound and optimize for video sharing. Always a good thing.
There's a lot of power in the way we use language. Power that can profoundly affect the way people think, feel, and act. Take this example. Would you be more willing to agree to an operation if the doctor said you have a 90% chance of survival or a 10% chance of death? It's the same probability, yet not many choose the latter. So the question becomes, when we talk about drug-resistant infections, how can we ensure the language we use is effective and drives action? We tested different ways of communicating about drug-resistant infections in 7 countries, and 5 themes emerged. 1. Frame drug-resistant infections as undermining modern medicine. People understand the gravity of the issue when they see the impact on treatments we all rely on. For example, say that cutting-edge cancer treatments are failing as drug-resistant infections rise. 2. Explain the fundamentals succinctly. When the science is easy to understand, people are much more likely to get behind the issue. For example, explain that infections become drug-resistant when the bacteria that cause them adapt and change over time, developing the ability to resist the drugs designed to kill them. 3. Emphasize that this is a universal issue. It affects everyone, including you. People are much more likely to act when they feel the issue is personal and affects their friends, family, or themselves. For example, say that drug-resistant infections are putting us all at risk. 4. Focus on the here and now. The issue moves from tomorrow's problem to today's when our focus becomes now. For example, say that people were already dying from drug-resistant infections, and as more drugs stop working, more lives will be put in danger. 5. Encourage immediate action. People are much more likely to engage and spread the word when they feel the issue is urgent, but there is some hope. For example, say that we can get ahead of the problem by developing new antibiotics. For tips on how to effectively communicate drug-resistant infections, visit welcome.ac.uk/reframing-resistance.
So I think this is a fantastic kind of step-by-step idea of how to use even your everyday interactions with people to communicate about AMR in a way that brings them into the problem, makes them feel like, yes, it is indeed something that is potentially very, very close to home for them. Because one of the problems that people have with this is that until they experience it directly or know someone who has experienced it, it feels like an extremely remote issue. It's complicated, it's multifarious, as you've been looking at over the past summit, but it's also something that until it happens to you, you don't want to think about it, and therefore you don't think about it. So what I'm going to do is just stop sharing for a moment, and what we're going to do is what I call a waterfall in the chat. So we're going to take 1 minute, and everybody on this Zoom, just take a minute to think about one message that you have heard in the past summit or previously in your studies, in your professional life, about AMR that really, really made it, brought it home to you, or a message that you heard that felt impossible to get your head around. So either one, you can say a really, really good message that you've heard or a really ineffective one. So we're going to do a trick where you type your thoughts into the chat, but don't hit send until the end of the meeting, at the end of the minute. So I'm going to count down for 1 minute now, type into the chat, and don't hit send until I say, all right, send. 1 minute. That's 30 seconds. Okay, that's 1 minute. Everybody hit send and watch the chat go crazy. This is fantastic. This is really useful to me to kind of see what people have heard over the past days of the summit. Fantastic. AMR kills more than HIV/AIDS, and yet public knowledge is low. It's crazy, isn't it? It is both natural and our fault. Hard to hold those two things in our minds at the same time. Global problem, not individual issue, and yet we ask individuals to take action. Another contradiction. To not wait for the perfect opportunity, but rather act first and communicate with the relevant figures and go from there. That's right. Don't wait for the perfect. Go with what you've got right now. Understand that AMR is a global threat. Yes. And prevention is better than cure. Same goes exactly for AMR. Yes. A slow tsunami. That's an evocative image. Antibiotics are not candies. Fantastic. Yes. All right. So thank you for those thoughts. We're going to go back to the share. So taking these 5 points, we're going to think now about each one of them and the way that we can put them into use, into communication, both one-to-one in person and online. So the idea that when we speak more simply, science is easier to understand and people are more likely to get behind the issue. People are also more likely to act when they feel the issue is personal and affects their friends, family, or themselves. Moving the issue from tomorrow's problem to today's, when our focus is now, when the issue is urgent, but it also feels like there is some hope. So if people feel that it's urgent, but there's absolutely nothing that can be done, they want to put their head in the sand and roll over. So the framing toolkit that the Wellcome Trust put out is fantastic in terms of giving you more in-depth ideas about how to use this. Again, I'm going to step through this very quickly, but the same 5 steps are expanded in more depth in terms of what we do in order to make this understandable to the non-expert public. I highly recommend that everyone have a look at the entire document there. Because in addition to showing you an example of a headline narrative, so common infections and injuries that were once easily treatable are becoming more dangerous and killing once again. They're kind of color coding each one of the 5 concepts in this phrase. That this is because of drug-resistant infections. They also encourage people to use the term drug resistance infections instead of antimicrobial resistance because it has been tested to be a form of language that people are much more likely to understand, which are undermining modern medicine. And then they expand that into a long form supporting narrative, sort of saying that in addition to being able to sort of explain the concept in a nutshell, it's really important to be able to support that message with more detail to give people a better sense. So with these 5 concepts, what we're now going to do is apply the citizen science fiction method to this communication challenge. My doctoral project, Shadowpox, was a co-created networked narrative that explored the science and sociology of vaccination through a superhero metaphor. For the Shadowpox disease at the core of our story, we actually created a mixed reality shadow virus that was projection mapped and motion tracked onto the body. And then we invited young people from around the world to create a character who was a volunteer in a phase 1 first-in-humans trial for a shadowpox vaccine. They got to think about risk and the heroism that it takes to step forward to help test a new vaccine, taking action in the hope of protecting hundreds and millions of their fellow humans. Like climate action and antimicrobial resistance, vaccine hesitancy has been called tragedy of the commons, or a collective action problem. In the case of vaccines, when enough people are immunized to make it difficult for a disease to spread, herd immunity can protect even the unvaccinated. Call this the immunological commons. But this protection means that more people feel safe skipping the vaccine, which then reduces the collective protection shared by everyone. And as a result, a once banished threat like measles inevitably comes roaring back. For humans to take collective action, we need communal meaning making. And making meaning is what storytelling does best. However, this power of storytelling can be used for creative or destructive ends. A storyteller can twist the facts and leave their audience afraid to take positive action. We call this kind of story misinformation. In 2025, the biggest misinformation threat on Earth is the attack on our collective effort to stop burning fossil fuels that wrap the Earth in an ever warmer blanket of pollution by switching to clean energy and electrifying everything that we can. So my next citizen science fiction project is The Undergrid, which reimagines the battle between the energy transition and climate misinformation in a solar punk scenario, turning solar power into a literal superpower, whose bearers are under fire from the merchants of climate doubt, delay, and denial. So what we're going to do is apply citizen science fiction to antimicrobial resistance. Biopsyops, the name of our story today, imagines a scenario in which microbes have developed computer literacy and are learning science communication in order to design viral media, disinformation, and other psychological operations, aka psyops, to undermine humans' defenses against infection. So, this is where you come in. Imagine that you are now a pathogenic bacterium and you've been hired by the Microbial Strategy Lab. Here are a few of your colleagues, courtesy of the fine illustrators at Vax Cards. So what we're going to do now is we're going to go into breakout rooms. And how many participants we've got? All right, this is the time where my co-hosts can get to do some math. What I would like you to do, we're going into breakout rooms of, I think probably we might get away with somewhere between 3 and 4 people per room. And your group, you are all now microbes who are trying to create misinformation to get humans to do the wrong thing. So using everything that you've learned about the right way to communicate about antimicrobial resistance, now you're going to flip it around and you're going to use all of your microbe brain to create misinformation around AMR to get humans to create more antimicrobial resistance. Are there any questions about this so far? Does anybody not want to play a microbe? Nope, it looks like everybody's there. We're here for it. Okay, so what we're going to do, we're going to have 5 minutes in the breakout room, and you and your microbe colleagues, I want you to come up with something short and sweet. So whatever your concept is for the best way to get humans to create more AMR, write it down in, let's say, 1 sentence, 2 sentences at the absolute maximum, and write it sort of somewhere either in the chat, but copy it from the chat, because once you come back from the breakout room, you won't be able to see, everybody else won't be able to see your chat. So make sure that you copy it into some other word processing program or something. All right, Any questions here? Repeat what you have to do. Excellent. So you and your, oh, fantastic. Thank you, Mohammed, for writing that down in the chat. Yeah, so you're going to the breakout room for 5 minutes, and everybody in there will be bringing their ideas. In fact, you know what? Let's do one more 1 minute before we go into the breakout room, and that means that everyone will have something to walk in with. So taking 1 minute right now, think about how you yourself as a microbe would frame the issue of antimicrobial resistance to promote it rather than reduce it. "30 seconds. I love it when people get into the swing. And there we go. That's 1 minute. Fantastic. All right, so what we're going to do now is we're going to put people automatically into breakout rooms. You should have between 2 and 3 colleagues in there, and you will then have 5 minutes before we'll issue the 1 minute callback. So effectively, you'll kind of have 6 minutes. And then we will bring everybody back and make sure that one person in your group has your idea written down that they will then be able to put into the chat. All right, let's go for breakout rooms. Thank you, co-hosts. It looks like there's a few people who are not yet assigned to breakout rooms. Does that mean that all of those are our moderators, our co-hosts? Excellent, because sometimes there's somebody who can't. All right, I will start the timer now. Fantastic. I have in the past, when I've done breakout rooms like this, put the recording on hold, because that way, you know, the people at the other end who are watching the video don't have to watch us sitting and waiting and talking about things. But then sometimes what happens is that you get so excited by all the things that people are going to come back with that you forget to restart the recording. So depending on whether people feel like we're going to remember it, we can pause it, or we can leave it running and say interesting things. We've got someone in the waiting room who is going to be very confused. How has the summit been going so far? And remember, you're on the record.
Well, thank you. The summit has been going really great.
Wonderful.
Can someone go to the room 41 of the moderators?
There we go. Yes, good idea. Yeah, and in fact, maybe we have, while we're waiting, we've got 3 minutes to go. So If each of the moderators wants to jump in there and see a room that doesn't have someone in, just join and see if everybody's doing well, if anyone has any questions. It looks like there may have been some folks who joined recently and need to be assigned. If someone can help out with those folks in the chat. We've got 2 minutes to go. Oh, someone was alone in their breakout room. I'm sorry about that, Gwen. There's a few more people who need rooms in the chat. Yes, when you've got over 250 people to organize into breakout rooms, sometimes it gets a little bit messy. But for those folks who haven't been able to go into a breakout room, you can still work on this yourself. You can just think about, if you were a microbe in the microbial strategy lab, what would you do to promote antimicrobial resistance?
Also, for everyone, you should receive a notification to join a breakout room at the bottom of your screen. So please accept it, because you are assigned to the rooms, from what I see, at least most of the people. So you just need to accept it, because we can't put you in the room if you don't accept.
It's like a video game. Put people into the rooms and more people join.
Also, if one of the moderators can go to room 25.
That's great. And we're almost at 5 minutes, so then we'll give the 1 minute recall. Oh, someone's alone in room 10. It's a soap opera in here. All right, that's 5 minutes. So let's call everybody back. Thank you, Anna. And it's 30 seconds until the breakout rooms close. So those folks who were not able to join a room, you will not be alone for too much longer. Sorry about that. All right, welcome back. That was the largest breakout room session I have ever worked with. So thank you to the moderators and the co-hosts for corralling that. That was an incredible feat of trying to get everybody put into a room. we apologize to the folks who didn't manage to get it or who had a room all to themselves so that they could brainstorm alone. But it was really great to sort of try this out with such a big group, and we will definitely be learning things for the next time we have several hundred people doing this exercise. So each one of the groups hopefully has 1 or 2 sentences at the most that they've got for how the Antimicrobial Strategy Lab should get humans to create more antimicrobial resistance. Excellent. And if you want to put that into the chat and hit send, go for it. Ah, this is good. Somebody's, I'm a microbe speaking for my community. This is MD Alamin. Most of us aren't harmful. We actually keep you alive. We help you digest food, protect you from dangerous germs, make vitamins, and support ecosystems like soil and oceans. Please use antibiotics carefully and avoid over disinfecting so you don't wipe out the helpful members of our tiny team. We just want balance and a healthy partnership, which is true. And the best misinformation has a kernel of truth. But clearly, this is something that you could then spin to say that absolutely no antimicrobials should be used at all because we're all your friends. Very, very nice. How about the other moderators? Anybody find anything that you particularly like and want to read out? We have Abir raising a hand.
Yes, hello, can you hear me?
Yes, go ahead.
I just want to share with you what we've brainstormed, me and my group.
Please.
We were thinking that if as microbes had the access to social media or apps, we can promote anti-AMR and have a whole week of anti-AMR and think of it as fake news and a propaganda against us because we are friends of humans and we won't harm them. So that was our our idea, and we also thought about filters and stuff where what we can use to promote memes, reels, and all sort of content that we can use. That's it. Thank you.
Fabulous. Thank you so much. That's great. Who else have we got? Who's got another good one?
Hello, good afternoon. Good afternoon from this place.
Go for
Sorry,
it.
can you hear me?
I can, yes, please. Go ahead.
Okay. So if I were a microbe, what would I do? Basically, as a microbe, I'll try to affect people with varying levels or with varying degrees of effect. In such a way, people have misconception of the fact that it is one microbe, because in that sense, they'll consider the microbe to be multifactorial. That is, so many factors come into play instead of seeing the
Oh, so for here, I think you went mute. For here, you're muted. Oh, maybe you had to go off microphone. Fantastic. Thank you for sharing that. Any of the co-hosts find others that you want to highlight?
May I speak?
Please, please, go ahead.
Yeah, for example, the microbes can convince the people that the antimicrobial resistance is not such an important concept. The governments are just trying to make it big a deal or something like that. But we are just trying to be consistent with the human, and there is no problem to be worried about, something like that.
Fantastic. This is great. Yeah, nothing to see here. Move along.
May I speak too?
Go right ahead.
Okay, I was thinking of an idea of how a microbe would think that doctors are trying to scam their patients. So doctors are not prescribing you antimicrobials. You get home and you get more sick and you go back to them and you give them more money. So it's just a scam.
They're just making money
Or
off
the
you.
microbes. Or
That's
the
great.
microbes can give
I
a
speak?
statement, for example, that how you're going to defend against us by don't taking antibiotics. So take as much as you want. There's no problem with that.
That's right. You know best. You should be able to prescribe antibiotics to yourself if you need them, right? Do they think
I have one. Um, so if I were like microbes and I wanted human beings to stop or to not worry about antimicrobial resistance, I would say that there is no need to worry because humans will make more antibiotics. So there's no need to worry about antimicrobial resistance.
Excellent. That's right. There's always a new technological solution, so nobody has to do anything differently, right? Where have we heard that before? Sounds like climate change. Great, thank you.
May I? May I?
Please go ahead.
I will, as a microbe, I will say that I will be more lethal and more dangerous if you use antimicrobials against me irrationally.
Oh, interesting. So how does that work? That I'll get
Means I will change myself. I will find the way you are going to kill me. So I will find some solution against you. So later on, you are not effective against me.
That's fantastic. Yes. Don't use these because maybe you won't be able to use them. It becomes a circular
Yeah.
argument. Good, good.
Can I?
Yes, go ahead.
Ma'am, may I ask?
So I think
Sorry,
as a
a second.
microbe, I will be manipulating my human to think of it as a gym. As a gym, if you take your antibiotics regularly, you become much more stronger. It's like going to the gym every day and you become stronger. It's the same concept.
That's fantastic. Wonderful. That's good. I heard somebody else asking. Yeah,
Yes, ma'am. Ma'am, may I ask a question?
please.
Yes, ma'am. Ma'am, for example, there's a case meningitis, which is a life-threatening condition, right? So, in case of meningitis, okay, so patient may can die within a couple of hours as well, okay. So, but if we will do culture and sensitivity test, so it will take at least 48 hours or more than that time, okay. So there's a empirical antibiotic therapy which is done by clinician based on just a microscopy, okay. So, ma'am, so it also can cause AMR now.
So you're asking me about a medical question because I'm actually not a medical person, but for the strategy about how the microbes could themselves get you to cause AMR, can you think maybe of a way to use what you've just asked to create misinformation around AMR?
So can I also say something?
Please go ahead.
Yeah, so if I'm a microbe, I would just say AMR is a scam. So they shouldn't listen to that. Then after that, I'll tell them that whenever they are feeling pain or anything, they can go ahead and take antibiotics. Then I also tell them that whenever they start taking antibiotics or they are being prescribed antibiotics and they feel better, they should stop using it because that's fine. Then I'll also tell them that once they have leftovers, whenever they feel like taking, they can take it and it will make them strong. So this is what I'll tell them to do.
Fantastic. Thank you very much.
Hello, can I say something?
Go ahead.
Yeah.
As if I would be a microbe, then I would say that don't worry, antibiotics work on everything, even the common cold. Just take them for every sneeze.
Fantastic. And they're probably good for weight loss too, right?
Yes,
There you go.
obviously.
Can I speak?
Yeah, okay. So I see also like we're having two raised hands, one for Ala and another one for Fajr. So please, Ala, if you are here, please you can proceed.
Go
And
for it.
all, if you have any comments, please raise your hand because like we need to have it more like organized. I'm sorry about this.
Very good. Please, yes.
So, yeah.
So, Mohammed, if
Yeah,
you
yeah.
want to keep track of the raised hands, that's great.
Yes,
Yeah,
I'm
yeah. So
here,
Ala,
and
yeah.
I'm very glad to joining all of you today. And I have a little bit things out of the box. It's like a narrative of a Mycobacterium tuberculosis. Okay, so I started as a microbe. Okay, you call me Mycobacterium tuberculosis You call my disease a tragedy. I call it a masterpiece of persistence. You are scrambling to create new drugs, but I'm patient. My waxy coat is my armor. My slow growth is my strategy. Your neglectness, the interrupted treatments, the weak health systems is my greatest weapon. We are tuberculosis. Your drugs are my training. Your complacency is my advantage. I have evolved, and your strongest medicines now fail. The clock is ticking. My resistance is your creation. Thank you.
Very nice. Thank you. Thank you. That's an epic. Wonderful.
Thank you. So we're having Fajr next one.
Uh, I thought about it about like microbes doing what humans do in real life, and it's like spreading the conspiracy theories and making like a whole stories about how the government is tricking us and the doctors are um, getting money out of us like this.
Yes, don't listen to any of those authority figures. They don't have your best interests at heart, right?
Yeah.
The government is trying to control you. Excellent.
Yeah, and we're having the last two raised hand, one for Safe and the second one will be Nisrina. So the first one is Safe. Safe, the floor is yours.
I think I always say that AMR is a scam, and however, you have to take antibiotics as a prophylaxis, not to be infected by TB or something else. And more of that, you have to stop the antibiotics in the middle of the course because you are treated, you are cured. Why to continue with the whole of course? Yeah, and
That's
why?
fantastic. Yeah. And if you can continue with the whole course,
You know
then
what?
maybe you'll
Why?
make them stop working.
Why to continue? It's renal impairment. Can cause renal
Exactly.
impairment.
There you go. Fantastic. All right. And I think,
Yeah.
Mohammed, you had one more?
Yeah, Nisrina. Yeah, Nisrina is the last one.
Okay, thank you. For me, in my opinions, to overcome these challenges, communities need stronger educations on responsible antibiotic use, better regulations of medicine access, improved hygiene and vaccination coverage, and also collaborations between health workers, school, and youth groups to build consistent community-wide actions against AMR. Thank you.
That's a wonderful message from a human, but if you were a microbe, wouldn't you have to say the opposite of every single one of those?
Can I say something?
Thank you.
Okay, so I think we are coming down to the wire with our time here. So thank you for everybody who's put these into the chat. What we're going to do is we're going to save the chat and look over these and maybe kind of share some of the best ones coming out of this for folks tomorrow. Do we have now any last questions? Well, first of all, I should ask Mia, how many minutes have we got left for a Q&A?
Let's see. I think we got 4 minutes.
Okay, then we can probably get two questions in there.
Yeah.
Back from your microbial brain into your human, and any questions that you would like. I love this. Please do not wash your hands. It's so refreshing to give bad advice when we're being so responsible all this time. Yeah, Mahika.
So I'm actually a veterinary student, and my doubt was usually I see cases where farmers, because they have an economic crisis or like they are pressure coming from the economic side that they have to produce profit because most of them are marginalized group. They are from a lesser educated background or they are having a very small sector farming. They see antibiotics as this growth promoting factor or this something that could potentially help increase their sales. So how do I convince them that this is like antibiotics is going to be something in the long run is going to be very bad for them, without having to, without them seeing this as like an attack to their livelihood?
That's such a good question. I think one of the things, kind of going back to the 5 points in the welcome advice, is to talk about this as a problem that is happening now. So the fact that they want to use antibiotics is, in a way, a hook for the conversation. If you want to still be able to use these in the future, misusing them now means that they're not going to do what you want them to do when you need them in the future. So kind of bringing the future into the now and kind of connecting those two things. But yes, it's a very good point. And the project that I'm working on next with the Global Strategy Lab is a comic book looking at AMR in smallholder farmers, using it with livestock, and sort of trying to bring that again into like a science fictional scenario where we're looking at a future in which AMR has been brought under control by decisions in the present. So once again, kind of connecting decisions that we make here and now today with a future that we want to be able to live in down the road, and our children and our grandchildren.
Thank you.
Thank you for your question. I think it's possible that that might be us for time.
May I ask one question?
One more question. Okay, let's try one more. Here we go. Go ahead. Was there somebody who wanted to ask a question?
I believe it was Dr. Darshan that was asking a question.
Yes.
Okay,
Yes.
go ahead.
Yes.
Thank you.
Yes. The implementation, even if the laws are there, its implementation is a problem. So it's all about the behavioral change. So how we can stimulate or what we can do for this behavioral change of the human being, as a patient, as a farmer, as an industrialist, like everywhere. What to do?
I think talking with people as human beings who have all of these pressures on them, and knowing, as the previous question said, that they have reasons why they do what they do. You know, if it's for their animals, it's because they really desperately need their animals to grow. If it's for their children or for themselves, it's because they can't afford to take time off work. So start from an understanding of why they behave the way they do now, as a means of opening up the conversation with them, rather than saying, you know, you're doing it wrong, starting from a position of that they're doing it wrong. Sort of say, let's talk about why you're using it, and then let's talk about how changing your behavior will help you get what you want in a larger sense, in the long run. This is one of the problems with tragedies of the commons or collective action problems, is that sometimes what people want as an individual, they can kind of like get a short-term gain, and you know, they don't want to think about, or they don't think about, or they can't afford to think about the long-term pain that that's going to cause, not just other people, but potentially themselves and their children.
Okay. Okay.
Thank you for the question.
Thank you.
All right, I think that is us almost at time.
Yeah, Alison, but there's another question in the chat.
Please,
In
yes.
our chat. Are there any specific workshops, courses, or training programs you would recommend for someone interested in learning how to communicate AMR through art and storytelling?
Well, let me put into the chat the link for our project so that people can keep an eye on it as it goes. Right here is the Art and AMR initiative. I would also say that the Welcome report, Reframing Resistance, is well worth a read. So this is the one that we were drawing on for today's workshop. So those two would be my top recommendations. I would also say anybody who wants to look at a little bit more of the art that we've been looking at in the slideshow, I've just put in the chat a scalar database that we've been assembling of lots and lots of different AMR art related projects. Well, thank you so much. I'm very, very glad that that people are enjoying the workshop, and it was really an honor and a pleasure to be here with you. And I hope that all of you go out there and be creative and not too misinformation microbial, but keep that in the back of your mind. What would the microbe do? And then use that to flip it around. Thank you so much, everybody.
Huge thank you for this creative and insightful session, Alison. And thank you all for your engagement and fantastic contributions.
It was really wonderful seeing everybody's ideas, and I'm sorry we didn't have 3 hours to go through them all, but we will be reading through the entire chat. So thank you.
Yeah.
And this is the last session of the day, am I right?
Yes, now we're gonna move to Slido to just do something to get to know each other a little bit. And if you want to stay, Alison, of course, feel free to stay. And after it's gonna take around 10 minutes, and after we're gonna take a picture. So you're more than welcome if you want.
Sounds fantastic.
Okay, give me one moment to share my screen. You can scan the QR code in the corner, and you can Google Slido, put this code. So the first question is to see the remaining participants of the day. Which sector are you from?
Wow.
We can see that most of the students are from medicine, but I have to comment here that it wasn't, I don't think that all the applications we had are representative because 40% were from medical background. So the statistics show that maybe relatively less medical students have joined. We have a lot of hospital work, I think. We have 24% dentistry, pharmacy after veterinary, agriculture.
Yeah, I'm feeling jealous right now from medical cities. Like they are, they are the one. But at
We
least you're
can move,
second.
we can move to the next question. So, if you could describe one word, the future of One Health innovation, what would it be? Feel free to share your thoughts. Try to keep it to one word. Tech. I agree. Bright. Collaboration, change, intersectionality. This is exactly what we're doing here, and thank you so much for writing this. Global, innovation, change, transformative, sustainability, chains, communication, AI, also something that's a lot in the forefront right now, prevention, together, patient-centered, also very important. But as we saw from the previous speaker, it's also important to allow and give funds to other sectors, not only like for human health, because they are affecting each other. Smart use, youth involvement, very nice. I like the spirit. Union, global efforts, partnership, team building, effective, efficient, public friendly, very important. We talked about public engagement in the panel earlier, sharing ideas, synergy, multisectoral, prosperous, selective, a lot of nice ideas. Thank you so much for sharing. Powerful. We can move on, I think, to the next one. If you had to communicate AMR in one of the following styles, which would you pick? I think this is also connected to the last session of the day of the workshop. Memes, TikTok videos, posters and infographics, short documentary, a rap dance battle. I think most people put TikTok videos and Instagram reels as well as memes. I think it is connected to what we discussed there earlier with Alison, but also to what is happening right now. We are in a digital world, but we still want to keep the human side. I think this is what we're getting from Instagram reels. You can have sound, you can have motion. It's not just something static, and usually there are also like people there that you can feel connected to. We have some people in the chat that say rap dance, reels, TikTok. Memes are funny only if you have the background. That's also true. TikTok and Instagram are the main sectors. Perfect. And moving on. We have a live quiz. So please join with your name. I see a lot of people joining. Thank you for that. Okay. So the first question of the quiz is, what does One Health primarily aim to address? We have hospital emergencies, nutrition issues, mental health crisis, and interconnected health across humans, animals, and environment. Perfect. 97% correct. It's very good. What is currently widening in AMR research? The training gap, the education gap, the innovation gap, or the climate financing gap? And the answer is a lot of people put the innovation gap, but also the education gap is a very popular answer. Let's see what is the correct. The innovation gap. But to be honest, of course, the other gaps also exist, right? And from place to place, there are issues that are not addressed also in these areas, widening the gap there. Moving on, which is an example of AMR innovation? AMR themed conferences, rapid diagnostics, bigger hospitals, or more antibiotics everywhere? Innovation. Let's see what you voted for. Many AMR themed conferences, mostly in rapid diagnostics. For the people that voted more antimicrobics everywhere, I think maybe this isn't the answer. But maybe you are still in the microbe role and you think we should have more antibiotics like everywhere and just using them all the time. But let's see which is the right answer. Rapid diagnostics. Of course, AMR themed conferences are also important, but like the innovation field is mostly in the diagnostics. And stay with us for a little bit more. Which skill is key for AMR advocacy today? Graphic design, communication, research, and marketing. Try to think of what we did during this day. The questions are not random. A lot of people said communication. Second one is research, and then graphic design and marketing. Yes, you're absolutely right. Communication is the main one. That's why we wanted to do this workshop on AMR communication and how like to advocate and how to say our advocacy messages in the correct way. And then, of course, research is very important. Next question is, what makes AMR communication challenging? The fact that there is no data, that the fact that AMR is new, lack of memes, or that the fact that people don't change their behavior easily. Most of you voted for the last one, which is correct. We discussed a lot again in the panel of how it's very difficult to change the minds of patients or for people around the globe on antibiotics. And second to last question, what does the professional collaboration help reduce? Research output, gaps between sectors, Zoom fatigue, or community engagement? Most of you voted for gaps between sectors. And some community engagement, which I think is also valid. But the main one is gaps between sectors. Great job. And the last question for everyone, which youth action is most impactful for AMR innovation? What can we do as youth? Posting random facts about the AMR, blaming the older generations that they don't know how to use antibiotics, sharing evidence-based solutions, or waiting for policymakers. Sharing evidence-based solutions. I think most of you agree on this, which I think is correct. Great. Let's see the leaderboard. Great job, guys. We had some very quick people here. Amazing. thank you so much for joining to do the questions with us. And now please open your camera so we can take the picture of the day. After we finish with the picture, we will share with you also the attendance form. Perfect, I see a lot of smiles. Get ready, because we have a lot of people today. You see more and more cameras open. Okay, I think we can start taking the pictures. Please try to keep smiling when I tell you, because we have a lot of slides open. So we will need to take some time, but we will start now. Please smile. Continue smiling. Please don't text in the chat. Continue smiling. We're only on the 4th page and we have a lot. Just a few more. Please don't close your cameras. Okay. I think that was everyone with their cameras open. Thank you so much for joining. We need to send the form. I think it's not in the chat at the moment. Thank you so much, Alison. We'll share the pictures with you. It was a pleasure to have you here.
It's a pleasure to join you. Thank you all.
You can see the QR codes here for the attendance. Please don't forget to fill it in. It's important to know that you're here so we can provide you with your certificates at the end. It's here. You need to scan the QR code. And also Musa texted the link. So please don't send any more comments to the chat so we don't lose the link. Thank you so much. And just to close everything, tomorrow, the same time as today, we're waiting for you for the last day at 12 UTC or GMT. It is the same thing, in case you were wondering. So please be there on time. We will have some very nice panel discussions and also some parallel sessions to see some more specific topics on AMR. The link is in the chat, but if you keep texting, you will not find it, so please try to scroll a little bit up. Mohammed Musa, moderator, has sent the link. The link says AMR Summit Day 2, so it's easier for you to find it. Thank you, Violet. When you fill in the form, feel free to close your laptop. It has already been 2 hours and maybe 3 hours and maybe a little bit more. We know you're tired. You don't have any other obligations here, so feel free to go rest. Thank you so much, Alison. Thank you.
A lot. Bye-bye.
Goodbye.
For those who are having any issues with the Bitly link, I also send the Google form link. So it's also like in the chat. So you can find both links.
Thank you, Mohammed. Does anyone want to share while we're here your experiences from day 2? As a recap, what did you learn today? I think there were a lot of fans of Alison here, so you can share some of these things as well. Anyone who'd like to share their experience of the day, please, you can type in the chat or you can raise your hand. Sahad says it was wonderful, looking forward to day 3. Rachel loved Alison's session because it was very interactive, that's true. Yes, Fazalur, go ahead. Yes, we are done. Hamad. Theophilus says it was awesome. Sandra loved everything, especially Alison. Both sessions were great, different perspective of AMR. Yes, go ahead. Mahdura.
I'm audible?
Yes.
Yeah, so I think really nice and great sessions like of yesterday also I attended, and today there is so much fun in the workshop session. In the breakout rooms, we really try to get involved in this and try to solve the microbe brain by using our human brain. So I think we enjoyed it, and with the quiz also, which was wonderful. So I think overall a great experience.
Thank you so much for sharing. We have also some other people in the chat. Mercy, I love the last session. What would the microbe do? And the Delulu and Sululu concepts found there in the scientific world. Mariam?
Hello Anna, how are you? How's everyone? I hope everyone's like doing great. I know you guys cannot answer like that, so yeah. Today's session was very interactive. I loved it, and I had so much fun yesterday. And today actually beat yesterday's fun. So every day it's getting better and better, and so it's making me more and more hopeful for the third day. It's kind of like sad that at 5 o'clock in my country, 5 p.m. I daily set through 8 or 9. It was 9 yesterday. So I'm going to miss this like 3 day session where I'm like sitting on the laptop at 5 and then getting up at 9 and all that. So I'm gonna miss all these speakers, organizers, and all of you moderators and everyone. Like it kind of feels like we've formed like a sort of a mini family situation right now. So I'm gonna miss you guys tomorrow. So I'm gonna say that tomorrow, not for today. But today's session was so much fun. The interactions, the quiz, all sorts of things. And I would love to see more interactive sessions in the future. How the colors, illustrations, and everything was so catchy and at the same time super easy to understand. So great job, guys, picking up the speakers, doing all those and managing things. Great work. Thank you so much, guys.
Thank you so much for your feedback. Fazalur Rahman, yes.
Hi everyone. Hello. Am I audible?
Yes.
Dr. Fazlurrahman Khalji is here. Thank you. Today was very interesting topic about AMR. We really the mem question was really interesting.
I think we lost you. We also have some other comments in the chat. Great sessions, thank you. I think you all like being microbes. I know what you will dress up next year for Halloween. Perfect. So I think that's everything. We can wrap up the day. Go rest. It was great to see you. And see you tomorrow at 12 UTC. Same as every day. Thank you so much.
All right, guys, we are closing the Zoom for now. I hope everybody has filled the attendance link because we're about to close the Zoom chat. All right, see you all tomorrow.